Certainly I have a large clinical practice treating AML in Wales. That's what your day job is, because that's where we treat all the acute leukemia in adults in our area. AML, this particular session was devised as a debate to try and put both sides of the argument, and I was asked to, and therefore undertook to argue on the side that the way forward will be targeted therapy, and the other side of the debate that it was an immunotherapy. Slightly false argument, I think, as these things always are, but I certainly looked into it and tried to argue the case for which I had been given. But I think there are lots of new treatments, both bits of the crossroads. Targeted therapy, so we are certainly in the era of where we know of molecular medicine, where we know and are getting increasing numbers of driver mutations, of known mutations, and there are a number of treatments devised against those driver mutations. And the idea that I was arguing was that as we get more of these treatments and learn how to use them, that basically the treatment of AML will change completely, because we will have, I think, probably personalised medicine, where we have treatments against the particular molecular targets. And there's quite a lot of evidence to support that point of view. There are arguments against it. I was, of course, using the example of CML, where we have started with a target and been very successful, but it is fair to say that's a very clean single target in AML. It's probably not as clean. A lot of talk about the number of different mutations, but they are small numbers compared to many of the cancers. So I think there's quite a lot of way forward in that. The other side of the argument was starting with the efficacy of bone marrow transplant, and then looking at some of the more immune therapies and checkpoint inhibitors and the place they will have in the treatment of AML. I think the issue, of course, will be how the combination will be used. But it was an interesting debate, and interesting to look at it.